Value-based healthcare is rapidly gaining traction across the globe as a model for transforming patient outcomes and experience in a financially sustainable way. This makes it a key priority area for us at Life Sciences Hub Wales. Wales is already beginning to embrace the long-lasting benefits of value-based healthcare. For health and social care providers, it means implementing sustainable services that better meet any challenges and priorities. For patients, it means focusing on outcomes that they find important. For industry, it means developing innovative products, services and solutions that put the people of Wales at their heart. Life Sciences Hub Wales is here to help make this happen. We want to help the life sciences industry demonstrate the impact of their products and services within this growing field. Our dedicated team is on hand to plug innovators into the value-based healthcare ecosystem in Wales. We orchestrate multidisciplinary networks where industry can play an active role in co-shaping the future of our health and social care through knowledge sharing and collaboration. If your ambition is to be at the forefront of value-based innovation and you want to develop meaningful partnerships and help to co-grow this dynamic system, then we want to connect with you. Wherever your business is based, we can help. So let's start the conversation. Life Sciences Hub Wales is proud to be working collaboratively to make Wales the place of choice for health, care and well-being innovation. Join us as we make our shared vision a reality. Contact us at hello@lshubwales.com or visit lshubwales.com to find out more.
So good morning, everybody. Shamelessly sharing our explainer video there that my colleague John worked extremely hard on with our team and with others. Welcome to this morning. Great to see so many of you joining us. I'm just going to share my slides, so I hope this is going to work okay. I think we've all been in this position this year, so just bear with me just one moment. So I'm just checking everyone can see my slides. Yep, fantastic. So as we said, good morning. My name is Dee Lowry. I'm head of value-based healthcare at Life Science Hub Wales. Great to see so many of you joining us. This is the second in the value-based healthcare industry specialist interest group for Wales. At our inaugural meeting in January, we really tested the landscape and your views, and I tried to identify what some of those key challenges were and the key themes that were really going to help you and your organisations and in your collaborations with health and social care in Wales to really be able to move forward in a value-based healthcare approach way. So this second session has really picked up on some of those key themes, and I'm really pleased to share this agenda with you. So there will be opportunity for interaction and questions, but we've really set this agenda around those key areas that we were discussing last time. So I'm going to just cover a bit of a welcome, a little bit of value-based healthcare in Wales, and we'll lead into then the value-based healthcare Wales ecosystem and why partnerships are so important in this area. I'm really pleased to have Adele Carr, the Assistant Director and Programme Director for Value-Based Healthcare and Procurement at Mangan and the National Value and Health Team in Wales. We will also be joined by Brian Mangan from the value-based, who is the value-based procurement project lead in the NHS supply chain. He's going to be talking to us about the report that was recently launched and the pilots that took place and some learnings from that. Really pleased, so data and digital transformation, access to data, collaboration on data, and also the pooling of your data was a key area that came up in our meeting in January. So I'm delighted to also be joined by Navjot, who's the Assistant Director for Digital Transformation for Value-Based Healthcare in Swansea Bay and the national team, and Sally Cox, who's the Principal Specialist Information Lead for Value-Based Healthcare at Digital Health and Care Wales. Following that then, what we'd be really pleased for, if you have any questions during this time, pop them in the chat, and then we'll have a session then where John Morgan, our project lead, will be leading those questions and answers with our panel. There is some interactivity in this session, in the data session, so you're not just a sitting audience. The whole point of this is to really develop and work together. And I've just popped up the future dates there for the next SIGs that we've popped in the diary, subject to change depending on availability of our next lot of speakers. We're hoping to do a bit more on critical success factors, and Adele will be touching on that slightly today, but we really want to get you involved around what are the critical success factors for value-based healthcare for industry, and how do we then co-develop on those at our next meeting on the 16th of September. So just to recap the context in Wales. So we do have an implementation plan, a 3-year action plan for Wales for value-based healthcare, directly linked to our Healthier Wales strategy, and the design principles around increasing the value of health that we actually deliver in Wales, aligned to and driving forward the prudent health principles. It's clearly identified in our strategic approach the need for improved innovation partnerships with industry, and really helping health and social care to understand what industry can offer, and to open those connections around what the key challenges are and how we can co-produce on those. We're still in the situation, and probably even more so now, finite resources, and that's not just the financial element, but expertise, time, accommodations, and these are clearly increasing. At the same time, the need for better health outcomes, which are co-decided and take into account what the patient deems as important. We have seen increased digital and data capability through COVID. We in Wales really want to ensure that that continues to drive forward. We recognise there's still work to do, but also there are also clearer opportunities to drive that with digital partners and with industry across data and digital, and particularly around value-based healthcare, and Sally and Navjot will touch on that a bit later. The need for personalised care in health interventions and taking into account those experiences and outcomes on the patient is a clear driver, and is a clear benefit for supporting those clinical decisions in procurement, but also for industry in the R&D and the product chain, and being able to be closer to those patient experiences of products is a key benefit. And clearly we've got the impact of COVID. So we know that the pandemic has increased inequities, unwarranted variation. We know that it's impacted on behaviours of patients and of staff, and we know that there's also burnout and backlog, and that widening of the equality gap. So we've all got a lot on our plate. We've all, there's a lot of context going on. So one of the clear things that we pulled out from our January meeting was around defining value-based healthcare, and this is based on the work of Michael Porter and a lot of the experts following on since. So we know where the problems are. We know that there's overuse causing waste and patient harm. We know there's unwarranted variation in access, diagnosis, treatment and cost. That's not always down to access to care, but sometimes down to lack of knowledge and of innovation and opportunities, as well as inappropriate care delivery and treatment. And we know we're trying to get patients to be cared for at the right time, in the right place and by the right people. We know that there's wasted resources and underuse of appropriate interventions, potentially because they're higher cost, but that's normally when it's in a silo situation. So we really need to move to that overview, systematic approach, and looking at the whole of the patient journey. So value-based healthcare built on 4 pillars really. So really looking at that personal value, enabling patients to achieve their personal goals and improving their outcomes and experiences. Technical value, so the achievement of best outcomes with available resources. Allocative value, so that equitable distribution across all patient groups. And the societal value, contribution of healthcare to social participation and connectedness. And societal value goes wider, considering the wider determinants of health, but also things like impact on the climate. And with the new NHS decarbonisation strategy, it gives industry an additional opportunity to identify where their products can help in this area as well. So the ecosystem in Wales. So we're really pleased to be joined by some of our national Value in Health team here today. As we mentioned before, the team is headed up by Professor Sally Lewis. There are also leads in each of the health boards, and Adele will touch on that later. Our role, as our little video said there, starting late last year, was really to start working with industry to identify what some of the challenges are, where some of the interest is, and start to drive some of that collaboration and co-production in addressing the challenges in health. And even since our last meeting in January, there's been a number of significant projects, and some of you are on the call today, that we've really been able to drive and develop in partnership to move forward, to really start looking at outcome-based contracts, but also review some of the contracts that are already in place and can be improved at no extra cost. Right, there we are. So shared services and the finance delivery unit have been working and training all of our finance leads on the value of value-based healthcare and considering the patient outcomes and experiences, clinical outcomes, as well as cost. Our newly named Digital Healthcare Wales, so previously known as NWIS, some of you may know, and Sally's here with us today as well, really leading on the data collection, analytics, dashboard development that we mentioned last time, which is so important in being able to evidence the change, monitor the change, and to inform those improvements as we move forward. Let's do it again. And as we had Hamish present last time, our new Value-Based Healthcare Academy as well. So providing those joint learning opportunities at Swansea University for health, social care, third sector and industry to learn together. And as we heard last time, and as myself and John and others on the call are doing, undertaking short expert courses, as well as the opportunity to access educational professional courses as well. And more information on that is still available on our website, and the courses are still open for application. So why value-based healthcare and industry? And I'm just going to run through this, and it was picking up on some of the themes last time. So why value-based healthcare? So it's firmly putting the patient at the centre of planning and delivery. Our life science sector is transforming from transactional to transformational, and we hear that so much from many of you in the meetings and discussions that we have with you, and your own plans in your organisations in recognising the changes to be part of the solution. There's a global shift towards value-based healthcare. There are increased expectations from patients and families. A wider societal impact to move to personalised care is recognised. It will enable the quadruple aim, and it does enable insights from data to inform research and development, evidence generation, pathway review and outcome-based contracting. So why Wales? So progressively, we are recognised as a nation aligned with an approach underwritten by Welsh Government strategy. We are globally recognised, so we are one of the first global innovation hubs for value-based healthcare with the World Economic Forum and the Global Coalition for Value in Healthcare. We do have the Value Academy, which has recently been affiliated as an expert innovation hub to the European Alliance for Value in Health. We have a countrywide integrated health system, which makes us a good test-based country for your other markets. And we do have access to data and real-world evidence. So why the hub? Most of you we've met. So we work with the national team, as you can tell, in partnership. We provide consistent expertise, which is free to industry. So we are funded wholly by Welsh Government to work with industry so that fees aren't paid, and to make sure that the information that comes through is consistent and collaborative. We work with shared services and the Innovation and Health Board leads to really identify where the key challenges and opportunities are. We're able to work with you, as we have already with many, providing advice and guidance, support on your value proposition development and business cases. We're developing training and toolkits, and as we're doing today, sharing this national learning opportunities and the opportunity to participate in the SIG and learn together. We're also, as I mentioned last time, leading on the development of a value-based healthcare charter for Wales, which will demonstrate the commitment and enthusiasm for organisations who are currently undertaking projects, research and contracts in Wales for value-based healthcare. So what's in it for industry? Well, you're all here today. So to support and understand and develop those transformational value propositions, to really understand and get that knowledge of the value-based healthcare priorities and opportunities in Wales, access to outcome evidence to inform your own product development, efficacy, efficiency and sales, reputational benefit and improved trust across health and social care and industry, which is such a key element. Upskilling your own workforce on value-based healthcare. This isn't just something that comes about at the procurement end. It is a cultural approach. It is thinking about where do we add value as an organisation, and that goes through the workforce. And the ability to use the learning and case studies from Wales in your other markets. So what's in it for health? And Adele will be coming on to this in just a minute, but it does enable those co-developed solutions with industry that are mutually beneficial. It enables us all to work together to optimise those care pathways with the latest innovation. And often there is not the time, the capacity or the capability to lift heads in health and care, to spend the time to identify what is out in industry and do that market research. So us all working together really enables that to happen. It enables our national value-based healthcare models to include the industry perspective, and that will be some of the work we'll be doing later on today and also at future meetings, so that industry are seen at the table as a co-player. It enables health to review the low-value, high-cost supply and processes, and to implement new contracting models. And we recognise the difference between pharma, medtech and digital, but also by working together, we can seek how those amendments and changes to practice can actually move forward. And it also enables health to test and improve the approaches with industry and for us all to learn together. So at the Hub, our model of moving forward is working with the pioneers in value-based healthcare, and we include this group and members of this group as the pioneers. You're here today, you're part of the value-based healthcare alumni and those of interest, and that's how we're really going to drive this forward. We've mentioned a bit about the environment, looking at the system and the pathways, the projects, the redesign, and we in Wales we do have these value-based healthcare enablers. So the academy, procurement communities of practice, this SIG, the intensive learning academies, and that's increasing. I've mentioned what we do at the Hub and how we can support industry on that journey. And then really it's all working together to look at this impact. So where is the innovation and the improvement? Where's the case study and showcasing? And then how do we actually replicate that in our charter? So I'm just going to hand over to Sally, who is just going to pick up here and then go into her own slides as well. So not Sally, over to Adele. Sorry, Adele.
That's okay, no problem at all. We've get mixed up quite frequently. So thanks, Dee. Great introduction there for us. Couple of things. First of all, thank you ever so much for inviting me today. This is a fabulous forum, and actually, isn't this a value-based forum? How many times would we have got 40 of us in a room big enough without it costing us anything, without us travelling to it? So this is a great, efficient way of doing things, and hopefully we'll all come away with something that we've learned and a really good outcome. So I think this is a really good test bed for some of that. It's also great to see, I can't see all of the faces, but I can see the names, and there's some great to see some old, very familiar names that I've worked with over the past, and also lovely to meet all of the new people on here that hopefully we can start to develop more relationship with. So I'm not going to take too long over this slide, but this starts to talk a little bit around who's who in value-based healthcare in Wales. And you'll see that some of my colleagues are here with me today, in particular Navjot Kalra, who's going to be filling in the space around data, and Sally Cox, who unfortunately didn't make her way to the stage in terms of a picture, but Sally and her team are equally as important as the others shown here. You'll see, I'm not going to read it out for yourself, but everybody here with a picture and a tab is part of the National Value in Health programme, which was established just under 3 years ago now. And this was born out of policy direction from, as Dee has mentioned, some of the policy that came out of Welsh Government around prudent healthcare, using value-based healthcare as a mechanism for delivering prudent. You can see on the left-hand side here that the sponsor within Welsh Government is Ivan Evans, and I'm sure many of you will have met Ivan in your venture around innovation and getting new products and solutions into Wales. And then just below that, you can see each of the health board leads for value-based healthcare across Wales. And what I've omitted from here actually are the shared services colleagues. So the likes of Jonathan Irvine, who's the Director of Procurement Services, and others. So Dee, if it's okay, and Jonathan, I will add a few more onto this, and then we can circulate again with the papers. So I don't want to spend too much more time on that. There's the link to the ValueBased Healthcare website and their Twitter feed there if you want to get in touch with us. So next slide, please. So as it says, I'm Adele Carr. I am the Assistant Director for Value-Based Healthcare at an Iron Bevan Health Board. Oh, that's your timing on it. Don't worry, leave it on that, Dee, it's fine. Yeah, no, it's okay, no worries. I've probably, well, I've been in the health service with a few years out in private industry for about 37, kind of up to 38 years. So an old dinosaur in this space, really. My background is as a procurement professional. I spent over 30 years as a procurement professional. Oh, you're going to have to stop it a second. I think it's on a timer, sorry, or something. Sorry. Yeah.
Hang on, if I do that.
Yeah, just take it off for a second. Leave it like that. That's absolutely fine.
Yeah, bear with me. There we are.
There we are, perfect. So absolutely been in this for a long time, and as I say, procurement professional for many years, working with many of you in your organisations as well over that time. And then 5 years ago, was asked by one of the senior executives at an Iron Bevan if I'd be interested in looking at helping supporting them with this concept of value-based healthcare. And I went in to provide the strategic leadership alongside Dr. Sally Lewis back in 2014 in an Iron Bevan. My role there has been very, very much around implementation. So how have we implemented outcomes to evidence some of what Dee described as the benefits, so reducing readmission, unwarranted variation and so on. But also in that time, I've worked within the national programme to advise Sally, Dr. Sally Lewis, on a number of areas. And over the last 6 months, I have spent time in an interim programme director role, which has been very much around setting up the governance structure, the portfolio management, etc., within the programme. And we'll be focusing now over the coming months and years in my specialist area again, which will be picking up relationship with industry partners and strategic partnerships. So I'm delighted to be here today. So this slide, which is, we'll leave it on like this, Dee, in case it jumps around everywhere. Yep. So this slide just talks really a little bit around, you know, what do we mean when we talk about value-based partnerships in Wales, and what is the current status? What's the landscape? And, you know, it's fair to say that there's huge enthusiasm across NHS Wales, and not just in the NHS, but across the whole of Wales in other care and other sectors. Loads and loads of enthusiasm. I guess the challenge comes when we try and commit to this. And we found exactly the same story when we were trying to implement value-based healthcare as a concept across health boards. It's really difficult to do it. Everybody understands the concept and the theory, but trying to make it happen can be quite challenging with a number of obstacles to get over. And hopefully what you'll see today from some of the work that Navjot and Sally will show you is how the data is starting to enable us to get over some of those challenges. But again, also this forum today is one of those levers, isn't it, around us all sitting around the same table, trying to fix the problems together. Next slide, please. So how do we engage in value-driven innovative collaborations? Well, this again is part of that. But what we must do, and we've talked about this for many years now, is shift away from pricing towards mutual goals. So making sure that we're all aiming to get to the same goal together collectively to improve the population health for the people that we serve across Wales, and to develop these value-based partnerships. Now, there is something around using value-based too often in these presentations. And actually, if we drop it, I mean, what does it actually mean? It's a common sense approach to the way that we work together, isn't it? It's in collaboration and not in competition with each other. And that's what really this is about. So I'm going to drop value-based for the next couple of slides and just talk you through the things that are really important. So there is something around us getting a collective improvement to the population of our health outcomes and reducing waste. And it was great to see that in Dee's, Not seeing the new slide, somebody saying in the chat bar. Is that a problem? Can people not see the slides? Hi, Christian, how are you? Yeah, can't see the slides.
I'm okay, but I can't see any new slides.
Oh, okay. What can you see on the screen?
I can only see the lovely pictures of yourself, Dr. Sally Lewis. And
oh, okay. Okay.
Hasn't moved on.
All right, lovely. Is that the same for everybody then? No. Okay. Oh, that's odd.
No, you can see the slides.
Okay, sorry, Christian, you'll have to bear with us and go with my narrative and we'll send them to you.
I'll look at them when they get sent round, Adele, it's fine.
Lovely, thank you. Okay, great. So reduction in waste, and this is one of the areas that I want us to focus a little bit on today and potentially to think about as we move forward, because again, people have got hung up on the fact that they think that we need to use outcomes to get these collaborative partnerships to evidence value. Well, we don't. There's a lot of work that we can do together to eradicate waste, harm and variation in the system, and working with suppliers and colleagues in industry to share some of their resource, their thinking and ideas to help us with these wicked problems. We know the NHS just don't have the capacity and capability in some instances to do this on their own. And we've got to open up the word and the meaning of partnerships so that we're in this together, trying to deliver, as we say, these good outcomes for the population that we serve. We need to identify new methods and measures. And, if I were to rehearse the story, maybe another day we'll talk about this, Steve. We'll put up a session on implementation, some of the real challenges in identifying these new methods and measures when you know what to do, but you just can't reach it. And data is one of those things. The challenge that I had early on around accessing the right data in my health board and being able to use that in a way. And as I say, Sally and Navjot will dispel some of those myths as they go through their presentation later. And as I said, in collaboration and not competition. Gone are the days where this is like not a win-win for everybody and it's a win for me and nothing for you when you walk away. Those adversarial approaches that we had many years ago, which I did enjoy actually at the time. And then a multidisciplinary approach, developing this more cooperative, collaborative approach to problem solving. And rather than industry coming to us selling a product, coming and saying, right, what are the wicked problems in Wales that we can come collectively as 1, 2, 3 and more providers, third sector, pharma and medtech to try and help you solve. Next slide, please. So it is important though, and I can't stress this enough, that we form the right relationships. And then when we go into this together, we go into it with the same values, not value, but the values, the behaviour, the things that we really want for people and that matter to us as individuals, the things that we would want to give if our family member was the patient or the population that we were serving, and that we forget some of the business approaches that have been with us traditionally. We must go into this with the right relationships rather than having too many relationships. We know there's a substantial time and resource commitment to doing this properly, and we have to be patient if we're going to get this to work. This is a long-term endeavour, not something that we can fix overnight. And as I've said, we are strapped for both clinical and analytical resources, and industry partners like yourselves are really best placed to provide us with some of this rather than trying to recreate this ourselves in healthcare systems. Next slide, please. So, how do we do this together? So some of you might have seen similar slides to this when I've presented in other places, but it's about trust, isn't it? How do we break down this barrier of perceived trust? Because I do think, again, if we pick the right relationships, if we sit around the table and we have the honest conversations about why we're in this, then we will find that actually we are all in it for the same gain. It is about providing the things that patients need when they need it and who needs to provide it for them. And, there's nothing more satisfactory for you as industry partners to be able to go back to your organisation and say the product or the solution that we've provided NHS Wales is making a difference to the population, is having a huge impact on the population that they serve. And for us as managers and clinicians to be able to see our patients' improvement in terms of their outcomes, but also to see that we reduce waste, harm and variation across the system. So what we've done, thank you, Dee, next slide. So what we've done in discussion with the Life Sciences Hub, we have taken the Boston Consulting Group mature model and looked at what do we think are the critical success factors of a true value-based healthcare system. And we have plagiarised it a little bit in terms of the things that matter within Wales. And I think, you know, and Dee can help me out a little bit on this one. This is what we're thinking might start to shape our relationships in this SIG moving forward, to think about how we can help each other to meet the standards, the IT infrastructures, the challenge of the information governance issues, linking cost and all the other factors that that are included here. And in particular, you know, things like, you know, how can we engage with industry to inform our innovation, our R&D solutions. And more what we're seeing across NHS Wales are the forging of innovation hubs in health boards where they are formally integrating research and development, improvement, innovation and value. And a little plug for myself from an Iron Bevan. We have just launched or about to launch an Iron Bevan Connect, which is doing exactly that, bringing formally those integrated functions together so that when we're looking at a wicked problem in the organisation, we're looking at it through the lens of each of those hubs, and we would need industry around the table with us. So Dee, I think, you know, that's just a plug really for the SIG moving forward. That this is something that we'd like to shape up as a model that works for all of us on the call. And that's it from me, actually. Just thank you very much for your attention. I know it's very short and sharp. We've got a lot to get through today, but hopefully that gives you an overview of where our thinking is across NHS Wales. Thank you.
Fantastic. Thank you very much, Adele. And yes, so Adele shared with us the critical success factors, and in some of the meetings that we've had with some of the people on the call, and we've been developing, co-developing our business cases. Shock and Ravi, you know, we've seen this and built it into our work and really collaborated on it. And we're really keen then at that September meeting that we can look at that model and then consider it from the industry point of view. So what are the critical success factors for health and social care, but what are the critical success factors for industry that we need health to be aware of as well? Because if we're all on the same boat, then we've actually helped to co-develop that, and we can actually use that then as a national model moving forward. So thank you very much, Adele. Some very helpful presentation there, very thought-provoking, and really meeting the needs of some of the key areas that we identified last time as a challenge about understanding what was happening in value-based healthcare in Wales. So a great start for the conversation there. I'm looking, excuse me, so we're going to hand over now to Brian Mangan. I can't see him on screen. Brian, can you make yourself known? John, has Brian joined us?
I can't see him in the participants. I'll just chase it, you know, if he's
Okay, if you chase Brian then, Navjot and Sally, are you okay if we move on to you and then we can bring Brian in afterwards rather than us all waiting around? Is that okay?
Yeah, that's absolutely fine.
Oh, perfect. So we'll hand over to Navjot and Sally, who are going to be covering intelligence and value and data on value-based healthcare. So over to you guys. Thank you.
Okay, thank you. I'll just share my screen. Bear with me. Okay, can you let me know? Can you see the slides, Dee?
Yes.
Brilliant. Okay. So hi everyone. So I'm Sally Cox. I work for the Value and Health team, but I'm based within Digital Health and Care Wales, and I'm here with Navjot as well. Navjot Kalra, Assistant Director for Digital Transformation. So we're going to talk a little bit today about the role of our team of data within the national team, what we've done to date, and show you a couple of our products and a quick overview. Okay. Right. So, like I said, I work for Digital Health and Care Wales. So that's a national organisation which supports health and care technology used throughout Wales. if you weren't aware. And we collect data from numerous sources across the Welsh NHS and maintain a range of national databases. So my team sits within the information team. There's 4 of us, and we use the data collected nationally to produce products as shown on the screen to support the National Value in Health programme. So to date, we've created data visualizations to support direct care, showing an individual's PROMS trajectory, which is embedded within the patient electronic record within the Welsh Clinical Portal. And we've also produced 4 outcome data dashboards to serve to support service planning and quality improvement. So these products make up the Value in Health products. So a little later, I'll give you a quick demo of the first phase of the heart failure dashboard, which brings together multiple data sources to show you what we can do nationally. Navjot will take you through some heart failure PROM analysis carried out at Swansea Bay Health Board. But first, I'm going to give you an overview of our journey to creating the Intelligence for Value framework. Okay. So first of all, when we were thinking about what data might be needed to create a value-based data dashboard, we had to take a step back and examine the complete patient journey. I think this was mentioned earlier. So we're looking at the patient's journey through the system from beginning to end to see what data sets, in terms of data sets, what data sets they might come across or be part of as they travel through. So this is a very basic diagram to try to illustrate that. So very often disease area analysis focuses on single data sets, but this is usually due to data availability. But when we're trying to examine this value and variation, we need to, it's important to study the entire journey. So like I said, this shows a journey through from an information point of view. So our intention then is to support the improvement of outcomes, and to do this we need to bring together all the available data and provide a whole picture approach when trying to support the identification of variations. So the digitisation of services, joining up of local and national systems in recent years, particularly during the COVID time of the last 18 months, has enabled access to more and more of these national data sets, which provides a more complete picture of the patient journey, which would allow us to start making comparisons nationally. So we flick to the next slide. It's rather busy. There we go. But what I've done here is I've highlighted the data sets that we have access to in the National Data Warehouse, also where the data gaps are. So the red shows the ones that we do have access to. As you can see, we do have access to a good percentage of the data. The yellow shows this data, highlighted in red is patient level, so it's available for linkage. There's some extra yellow data sets there, which are summary level, which may be helpful, and the green then the data gaps. So data sets are collected for specific uses generally, and utilising these for different purposes can often lead to flawed analysis. So this is something we also have to be mindful of. So as you can see, we have lots of data, but turning this into useful information to drive improvement is the difficult bit. And for this reason, we need clinical and expert user groups, engagement to sense check the data, provide us with ongoing feedback so we can create iterative products that evolve to become very useful for our users, so that they can also realise the value of putting the good data, the correct data in at the start. So the 3 blue areas that are highlighted there are the main areas that we want to use the core data sets, PROMs, audit registry data and costing data that we want to use to triangulate to determine value. PROMs data flow nationally in Wales is a bit patchy. It's for certain clinical areas only. This is because we have many PROM suppliers. Currently, we only have access to the data nationally that comes from our national platform, but there is the parallel piece of work that's going on to create a flow of PROMs data from third-party suppliers. So Wales does not currently collect clinical outcome data, either in the form of registry data or audit data. The data tends to go from the hospitals directly to the national registries, but given that this is so fundamental to support a data-driven, value-based approach, we've also embarked on a journey to enable this data flow. But as you can see, there is a huge array of the data collected nationally that can be linked and analysed, and we can start asking questions of the data straight away. Okay, so on to Navjot for this slide.
Thank you so much, Sally. Can you all hear me? Right, great. Okay, so as Adele alluded to earlier, information about patient experiences and patient outcomes is vital to value-based healthcare, but that's not the only thing we need for value-based healthcare. There is, so these 4 elements that are on the screen. So as Sally alluded to, we've got costing and activity data sitting somewhere else. We've got clinical outcome and registry data not in our gift at the moment. And we've got patient reported outcome measures that are measured across various different platforms. Unfortunately, you know, there are data standards. So fortunately, there are data standards for prompts, but as with every system that's trying to grapple with value-based healthcare, the data standards are not yet there, and so isn't the appropriate interoperability. So what does all of this mean? Well, all of this means is that collaboration with suppliers to ensure interoperability with patient and clinical portals is vital, and that's where industry plays a huge role into it. Measuring standard sets of outcomes across Wales allows for comparisons that drive service improvements. When we get this information about patient outcomes and experiences, it fuels data-driven healthcare. And data quality counts as the essential step to using data well. And the first step really is to decide what should be measured and to implement a uniform approach across the country. So what Sally's described earlier, it's what's in our gift. But today, I think it's all about us understanding what's the things that you measure and what's the thing you would like to be measured in this joint partnership going forward. So that's a question I'd like to pose here, and please feel free to kind of start putting your comments in the chat, because we're here to hear, we're here to listen today. So when we measure the right things, that sets a common baseline with which to compare future developments, and it highlights services performing well from which others can learn. Now, what does that mean? That means by combining data on patient outcomes and experiences with information about the cost of care, it will be possible to select interventions and technologies that deliver the best value, as Adele alluded to earlier. So for example, PROMs and PREMs, when combined with the information of cost of care over a 10-year period, will give a fuller picture of how various treatment choices contribute to the goal of improving patients' life. In practical terms, it may influence decisions about which hip implant, cardiac stent, or rehabilitation program to fund. So again, in my mind, all of this needs to get together in one place for us to be making those data-driven decisions in the future. Sally, could you go to the next slide, please? So here is the aspiration. So with all the things sitting in different places in that jigsaw, the ambition is to bring this all together in what we are describing as the value intelligence framework. Now, the purpose of this framework is to understand the questions that our stakeholders are asking. There are many different interpretations of value across multidisciplinary groups. So clinicians will view value from a different lens, finance will view it from a different lens, services will view it from a different lens, I view it from a different lens, and you might also view it from a different lens. So what are the questions that you are asking? And what are the data sets that are in our gift? And if not, what do we need to acquire them? So the short term, you see this this journey that we're taking in NHS Wales is all about, well, we are doing some work on the dashboards, which Sally will show you in a minute, but dashboards aren't the answer to everything. Information needs to be at one place to be able to be analyzed for on a individual level, on a health board level, on a benchmarking level, on a policy level. And this particular exercise will allow us to understand the questions from our stakeholders, the data sets that underpin them, and actually bring it all together at one place so that they can be seamlessly embedded in clinical workflow. So the insights from this analysis can be seamlessly embedded in the clinical workflow. We will have seamless ETL processes, and I'm so sorry if I'm using abbreviations. So ETL stands for extract, transform, and load into the dashboards. And then the future of all of this is what we are calling in Wales is the National Data Repository. So all of this data that we're talking about goes into the National Data Repository for data linkages, and again, can be used at different levels for decision making. So I'm going to stop here and again, pose you all this question. So what are the questions that you are asking? And please feel free to use the chat and post as many questions as you can, because that's what we're here for today. Sally, over to the next slide, please. So yes, on to the interesting part, on to the more details. So what is it all about, this intelligence framework? Next slide, please, Sally. So here is the thing. We did this exercise with multidisciplinary stakeholders across Wales, and today we're doing this with you. So really, the key questions that stood out after doing this multidisciplinary workshops with clinicians, finance, others, services, policymakers, these were some of the key questions that stood out. So how do you define the cohort? How do you define variation? How do you look at cost activity? How do you define patient-reported outcome measures? How do you define clinical outcomes? I'd like to drill down into a few areas and what do those questions actually mean, and what are the data sets that underpin them? So Sally, over to the next slide. So here we go. So when we talk about variation, the sorts of questions that are asked in the space of variation are, for example, what's the prevalence of heart failure in Wales per head population? What proportion of acute heart failure admissions are seen by specialist teams in Wales? How many patients admitted with acute heart failure receive an echocardiography within 48 hours of admission? I'm not going to read through all the questions. Please feel to read them yourselves. But underneath each one of those questions is a data set that needs to be triangulated. Now, the business users are not necessarily aware of the data sets. And as data users, we aren't necessarily aware of the questions. The questions might be infinite, but the data sets are finite most of the times. So again, as we accumulate more and more of these questions and figure out the data sets that are required to answer the questions, we will be building a repository that enables us to answer pretty much any question if the data set existed. Over to the next slide, please, Sally. So again, one of the things I mentioned, unless we triangulate the cost and activity with patient-reported outcome measures or outcome measures, we won't be able to understand what is the variation in costs of prosthetics compared to outcomes. The traditional model has been look at the cost, perhaps look at readmission rates, but have we tried to understand what difference have we made to the patient? What were the patient goals? Did they just want to walk to their allotment, or did they want to run a marathon? So some of these questions are from, traditional measuring of cost and activity into triangulation of cost and activity into outcomes. And again, the questions are on the top left-hand corner, and on the bottom right-hand corner are the data sets that will be required to answer the questions. Next slide, please, Sally. So again, carrying on with a similar theme, we're talking about patient-reported outcome measures. So again, do outcomes vary by demographics? Do outcomes vary by the, I can't even say this. How do we define harm? And again, underlying those are the data sets. So I'm going to stop here now, and I'm going to ask you this question again, and I'll keep on asking you this question today, is we want as many questions from you in the chat box, please. And over to Sally for the next slide.
Okay, thanks, Navjot. So this slide really is talking about once we've defined those data gaps, and excuse me, I seem to have lost my presentation. There we go. Once we define the data gaps, and and we set about acquiring this data that we need into the national data warehouse. What happens to the data as it comes in? So, I mean, first of all, we can only get data in if we've got all the IG requirements in place. We've already got data sharing agreements between the health boards and Digital Health and Care Wales, but new data sets come with their own IG requirements. So given that that is covered, the data would come into Digital Health and Care Wales, into our acquisition team, where they then run data quality, validity checks, improve the completeness of any data. A lot of data we have has poor NHS number. We have NHS number tracing facilities. Data can then be pseudonymized for use back to the health boards or other NHS organisations. It wouldn't be pseudonymized if it went into clinical applications, but for use, by research it would be. So then we go on to facilitating record linkage so that we can look at this patient journey. We geocode the data and we map system codes to meaningful descriptions and groups. And then we have IG. So the data coming into the national warehouse, there's IG requirements. Also any data going out from us, then there's also further IG requirements. So currently we are trying to, as a national team, we are trying to work through a framework, an IG framework, but this is in its early days. All of our products currently have to go through a DPIA, which is the Data Privacy Impact Assessment. And with those, then we talk about, we have to state where the data will be stored. For example, we have data now stored in the cloud with the dashboard, so we have to have cloud risk assessments in there. We talk about who will use the data, who will have access to the data, what they will be able to do with the data, and so on. It's all covered within this rather long 32-page document. Okay, so then on from that, then I'm going to show you what we do with the data. So as a national team, then we've developed these products I talked about earlier. So I'll give you a quick demo now of one of the 4 dashboards we have, which is the National Heart Failure Dashboard. Just bear with me while I switch my screen. Okay. Does that work? Can you see the data? I know it looks like exactly the same slide, but it should have a menu down the left-hand side now and Power BI written at the top. Yeah, brilliant. Okay, so this is the national dashboard. This is an anonymized version of the national dashboard that we use for demos, basically. So there's lots of different sections here. If anyone's familiar with Power BI, this is how it sets up for the menu down the left hand side, different tabs that you can click through. So if we just go through a couple of them, hopefully it'll load quickly. I just want to show the interactivity of the sorts of things that we do. So this is a summary of audit data. So this is one of our key data sets, our clinical outcome data. This slide is showing variation basically across the health boards for key metrics across the audit. The idea is that the health boards can come in at any point and view themselves with regards to audit data once we get the data flow in and more real-time, near real-time. So there's lots of bits and pieces in here, but what I really want to show you is the sort of data that we've triangulated, that we've added value to. So this here, on this page, now we're looking at the effect of comorbidities on mortality and on the length of stay of heart failure patients. So this is clinical outcome data that's been triangulated with admitted patient care data and also mortality data at the bottom. This is all completely interactive, so anything you click on within the dashboard, you can click on and off, or there's all filters down the left-hand side so that the data can be explored. So as I said before, the idea is with this first phase is that this is a way of exploring data to raise questions. So for example, if we were interested in the effect of comorbidities in patients with a history of valve disease and whether this was affected by specialist input during their stay in hospital or not. You know, you can click through things like this. You can look by age, by hospital site. It's all just explained down there, whether they smoked, whether they didn't. There's lots of different factors that you can bring in to try to explore what's going on with the data. So we find that helpful with our clinical reference groups that we've spoken to, because they've said we often, if nationally we show things like this, there may be reasons why one health board appears to be doing less well than another, and they would like all these different filters to be able to explain their data. So again, we've triangulated some data with audit data on treatment tab, if it loads. And we're looking here whether on the effects of survival on patients that had 3 key drugs on their admission, or whether they were treated with aspirin, yes or no. And again, you can click through these. Again, specialist input by sex, by whichever you wanted to know, or any particular provider, and click through, and all the windows will update. Okay. So I think we've mentioned readmissions a lot and how this is typically used to determine value. We've worked a lot with clinicians talking about costing and wanting to cost readmissions and triangulate that against length of stay. And we don't have costing data in the model yet, but that is something that we have available to us, and something that we are working through with our colleagues in the financial delivery unit. But here, length of stay, you know, just basic analysis. We can look at the length of stay, for example, of the health board with the highest rate of readmissions. Then is 5. If we look in comparison, the health board with the lowest rate of readmissions, it has a higher length of stay, which suggests that a longer stay in hospital may reduce the likelihood of a readmission. You know, as you know, there's lots of different things that can affect that, but this will start again getting the questions out there and getting people to start looking at the data. So that's it really. I mean, I could go through each of these tabs, but I just wanted to show you that, you know, what we've done, the importance of triangulating the data and the interactivity. I must say as well that Power BI, we've used this tool because it's free to us within the NHS with the Microsoft Enterprise Agreement, and it's available to all within the NHS then signing in with their Office 365 account. So users can access it on site or off site as well. So we needed something, you know, that's accessible. So if I pop back to the presentation, Navjot is going to take you through some PROMS analysis that was done at Swansea Bay, locally at Swansea Bay, on heart failure.
Thank you, Sally. So as you've already, you know, I hope you found the dashboard interesting. I've seen a lot of questions popping in the chat, and rest assured, we'll go through all the questions after we finish the presentation, hopefully, if Dee allows us to do that, and if time allows us to do that, really. So let me explain the context to you before I start going on the slides. So Swansea Bay University Health Board, which I happen to be the head of value-based healthcare there, have been going through a major heart failure service redesign. Now, traditionally, when service redesigns are done, we'll typically look at resources and costs and, of course, clinical outcomes. This was slightly different because when we started doing the service redesign, we started measuring PROMs right at the outset of the service redesign. So throughout the journey, we could actually measure, has the service redesign made a difference to the patient? And this is one of the snapshots of the analyses, which is readily available to the clinicians for them to view what difference have they made. So on this slide, what you see is the EQ5D, which is a quality of life prompts questionnaire response distribution across a domain. So EQ5D measures 5 domains, which is anxiety and depression, mobility, pain and discomfort, self-care, and usual activities. The difference with heart failure and any other chronic condition is heart failure is a palliative condition. So once you've got the diagnosis of heart failure, we are pretty much certain about the outcomes, which are not necessary. You know, it is mortality at the end of it. So a higher score on this one is actually worse, and a lower score is actually good. So what we're trying to manage here is you know, keeping people on the lower scores really over the course of their journey. You can also see this, Sally, if you do the next one, actually, it'd be probably easier to explain that for me. So this, again, this box plot visualizes that very, very nicely. So when we look at the mean, minimum, and maximum scores in the quartile ranges, that dot in the minimum. So as I said, the lower the score, the better it is. So we're really trying to keep people on the green rather than going over to the reds here. And as you can see, there is the number of forms completed over the course of the journey. They become lesser and lesser because people will deteriorate over the course of this time. But the idea is to manage them through this deterioration. And without completing the prompt and having this regular way of communicating with patients, you would have to bring them in your outpatients clinic and see them all over again. We don't have time to go through the other benefits of this project. But if and when we do have time, I'd like you to show that this particular project not only achieved the benefits in patient-reported outcome measures, but it also achieved significant efficiencies in terms of reduction of bed days, reduction of admissions, and all in all, what we could prove with this particular service redesign was that it's not impossible to achieve cost benefits and patient benefits at the same time. They're not mutually exclusive. And that's a really important message for the industry as well, that cost and outcomes are not exclusive areas. And most of the time, they can be achieved quite well together at the same time. Sorry, Sally. I don't think so we have any more. And again, this one was before the service redesign started and after, before the service redesign and after the service redesign. So again, a downward trend is improvements and an upward trend is worsening. So all these 3 visualizations show how we can visualize prompts in different sort of ways. Again, longitudinally to measure a service, to measure worsening of condition, and actually throughout a redesign or a utilization of a product, for example, it could be similarly done for products and technology as well. Yeah, so again, a similar visualization for all the particular domains for Kansas 12, which is a heart failure specific questionnaire. Again, you can see all the different domains of this prompt improving as we went through the service redesign as well. Yeah, so that's it from us. And any questions?
So, Jonathan, do you want to take the questions from the chat to Navjot and Sally? I've seen lots of, which has been fantastic.
Sally, would you mind putting the presentation down? Sorry.
Yes, I've just been frantically trying to digest and collate them. So I think I'll start with the kind of overarching one, which is do industry have access to these the dashboards, Sally? And I think that there was a comment about understanding the anonymized requirement for that. But I think that's a question that's come up really frequently in the chat. So.
Yeah, and we did anticipate this question. It would be great if we could, but at the moment we're in the early stages of working through the IG framework to enable access. So yeah, like I say, first time this has been done. We want to be able to use pseudonymized data to get it out there, but yeah, just working through with the IG team. So watch this space.
Brilliant, thank you. So just on the.
Sorry, John. Navjot.
Oh, no, sorry.
So just to complement what Sally said, I think it's really important that we uphold patient trust and the use of this data for appropriate purposes. That's really what it is. Now, appropriate information governance and applying the principles of information governance to particular user cases would be the ideal way to go about it. My understanding is that it'll be highly unlikely that we'll have a blanket approach to all of this. I think what is more likely to happen is specific user cases around the industry wanting to use this data for a particular purpose, which then goes through the usual information governance routes and data protection impact assessments. So again, we would welcome, I think that's what we're here for. We would welcome specific user cases that you would want to suggest. And actually, within our national team, we are developing almost like a standard operating process for, I believe, what's called the whitelisted organizations, Sally, which are on the frameworks or some sort of lists for DHCW. Whitelisted sounds quite fancy, actually. But really, I think what we're asking of you is what sort of specific user cases would you like to see aggregated, pseudo-anonymized data and specific questions that we might just be able to answer. You probably don't need access to all that data or dashboards because most of us will have questions and specific user cases. Does that make sense?
Yeah, I think on top of that as well, Navjot, we were thinking perhaps going forward, we would be able to publish, insights, high-level insights, something like that, to our website.
Yes.
Just sort of overarching messages and things that we found from the dashboard. So yes, that was another approach.
Absolutely.
Brilliant. Thanks both. I suppose that answers another question, which was about which came from Joe first about patient access to this and how aware have patients been of these changes and some of these developments around. So if we use the Swansea Bay example of heart failure, so what has been done to kind of involve them in this process, and also what has been done to kind of bring them on this journey around the change of practice and the way that things are happening?
So that's a really, really powerful question. I love that question. So step one, the answer to this is patients will fill in the PROM. So that's the first. It's there. It's the questionnaire that's sent to them. So step one, in order to use PROMs seamlessly during the entire life cycle of the patient care, we need to digitize the process, right? Because paper forms aren't good enough. So when we say digitizing, it has to be forming a part of their journey through the regular communications with the health board, digital communications. So I think somebody asked this question, are you digitizing your other processes? The answer is PROMs has to be a part of whatever digital processes the organization embarks on, which is, for example, appointment management, digital letters, etc., etc. Now, the first step of this is the patient themselves fill in this questionnaire that is sent to them, perhaps within an appointment, to fill in the questionnaire before the appointment. So again, they are active participants in this. When they then reach the clinician will be using the responses for these PROMs to be able to focus on what matters to the patient most. Do they want to focus on anxiety and depression, or do they want to focus pain in their knees, right? So that's what, so again, patient feels more empowered. They feel as if they are co-producing in the decision. Last but not the least, in terms of the maturity of an organization, we're not there yet in terms of patient portals. So clearly there are several solutions out there which are deemed as patient portals or patient records. If we were mature enough, then the PROMs visualization would go into the clinical workflow as well as the patient portals. But we do need interoperability for that, as I alluded to when I started my presentation. So we are, again, in the national space, we are on the journey, and one of my colleagues can perhaps come at the next SIG to describe some of the interoperability journey we're taking to make this happen. So the end-to-end flow. Sorry, it was a long answer, but hopefully that helps.
Adele, do you want to come in on that as well?
Yeah, lovely. Thanks. It's just really to complement what Navjot has said, but to say, you know, for every piece of work we do, we hold patient focus groups. So patients do actually work with us in terms of how we design the forms, in terms of their interpretation. We have to think about the education levels within the population in Wales and the different parts of Wales. So they do work with us, even though we can't change validated questionnaires, we can make the language more appropriate for the area. So an example of work that we've done is change tertiary to university because a population found that easier to interpret. So there's a huge amount of work there. I'm going to pop something in the chat bar which gives you some of the user cases on how we use the data with patients and also some little animations that can be used. So I'll pop them into the chat bar.
Thanks, Adele. Really useful.
Thanks, Adele. I'm just going to ask one more. Is that all right, Dia? We got some time just for me to ask a few more. So, yeah. I think someone asked a question about ICHOM data set, and Adele kind of answered that question. But I think it's really important that is the minimum, like Adele said in this, and everything above that is what is almost an added bonus of with a problem. So I think that's a really important point to make. Sally, someone's. One of the, I think it's Emma from Novartis has asked about how fresh the data is within the dashboards, and I know that I've been in a number of conversations where we've talked about how we can tell 6 months ago how whether someone was going to be readmitted to hospital. So are we in a position where this is improving, and can you give us an idea of how kind of live the data is?
Yeah, it's data set dependent, basically. We have data sets that are refreshed hourly. We have data sets that are refreshed annually. So there's lots of different, there's lots of variation there within the data sets. Our main data set, our biggest sort of most standard data set, the admitted patient care data, is refreshed on a weekly basis. So we're pretty much, up to date. We get daily death data. We're pretty up to date with the data for the majority of the data sets.
Okay, brilliant. And Emma's asked another question, which I think is really important. I think will be valuable to answer for the group. Is about, so you talked about data requests and for those whitelisted organisations. What's the timelines on something like that? So I suppose thinking from an industry point of view to kind of make that request to someone like Health and Care, Digital Health and Care Wales, not NWIS. So what are our industry colleagues looking at when it comes to that from a time point of view?
Yeah, it all depends on what you're asking for, really, to be fair. We do have an ad hoc request service within the information department, where it would be a paid service that is freely available to all, and they do industry requests quite regularly. Like I say, they are chargeable. The turnaround is pretty quick, but because we are primarily, because we are an NHS organisation and we primarily work with Welsh Government, anything from Welsh Government or NHS Wales, any requests would take priority there. So, but like I say, the turnaround is pretty good, and I would imagine within a month or so they would be able to get back to you, tops. But that's, I can give you the details of the information team if that's something that was required.
Brilliant. Navjot?
So just complementing on what Sally said, I mean, I think we've all got to understand that we are not the custodians, we're not the controllers of data. It's the patient who's the controller of the data in Wales, and the second layer is the health boards. So we are only data processors here. So again, the most time that's taken to process a request is to go through what sort of request is this? Is this in our gift? And once we understand if this is in our gift, then we've got to go for these processes internally as well. So it's not just, not just a special process for the industry. We will go through this process for any health board request or any request that I might have as a member of the NHS as well. So again, just to develop this shared understanding and trust between all of us, is we've got to go through exactly the same diligence ourselves internally as well.
Yeah, I should say as well about, you know, the majority of time with anything really that comes from outside the NHS is IG, you know, the IG process. So it is something we're working through to try to make that a little clearer and a little easier to get through.
And one of the questions that was asked in the chat was about standard operating processes. So we're more than happy to share our current standard operating process for information acquisition. It'll be fair to say that we're not there yet in terms of the process for whitelisted organizations. So we are developing that. And as soon as that's ready, Denise, we will probably use the SIG and the members here to circulate this as soon as that is approved through the governance processes of the National Value and Health team.
Fantastic. John? See, there's a few more questions and bits coming through. This was the time that we put in for the interactive bit, because we all wanted to really share where we are now. We mentioned it as a learning journey, but the questions are really useful because it helps us frame our moves forwards and widens the way that we think about this as well. So, John, I know I've just been through them. There's still quite a few in there, so we've got a little bit of time still, and then we'll hand over to Brian for his presentation.
Yeah, absolutely. They're coming through thick and fast now, which is great. So I think so Julian Dunnett just kind of made a comment about this collaborative approach of understanding what's important to industry from a PROMS needs and a data set needs. And I suppose that, and like Sally, you're saying that this is a very much an early part of the journey around sharing that, and I'm sure that will become clearer as we move forward in this journey. But I suppose the comment is around making sure that doesn't move towards a monetized revenue stream. So that I think that was the comment that was made, that effort and resource from our colleagues on the call is put into shaping the data to then not get access to it, I think is what the comment was making.
Mm-hmm. Jonathan, can I ask Julian to so I am looking at Julian's, is it Julian you said? Yeah, so I am looking at so if I am interpreting this correctly, I think Julian says we advise you of our PROMS needs, you collect, but we cannot see the resulting requested PROMS data in dashboards. So Julian, that's absolutely the intention of bringing the PROMS in the dashboards. We do have some PROMS with dashboards with PROMS data. The challenges we've had is the lack of data standards, which lends itself to sometimes inappropriate scoring. So that's an issue we're working on. So how do we score PROMs appropriately to be able to aggregate them? That's step one. And of course, we've had disparate systems collecting PROMs in Wales. So that's the second thing we're working on. How do we bring in data from all these systems into the repository, ensuring data quality and scoring for us to be bringing them into the dashboard. So we need to be absolutely sure that we're talking about that one version of truth, and sometimes it just takes a little bit more time. So we're just going through that process now, and rest assured it'll be as transparent as cost and activity and clinical outcomes in the dashboards, because there is no vision for keeping this separate at all.
Yeah, brilliant. Thank you, Navjot. And I think just talking about costing, so Shock from Roche has asked about what the activity around the costing part of that journey is, and developing the quality around this kind of data. So, and he's asked how much service line reporting currently occurs across organisations in Wales.
We are actually very, very good at service line reporting in Wales. I believe we have a system called Plex. We also use I think it used to be called Albatross, but it's called the HQVIA, I think now. Yep. Am I right, Adele?
You're right. Yeah, you've got it. Yes.
So we are terrific at service level reporting in Wales. We have a very it all comes through Oracle, I believe, and our procurement information comes from Oracle. And we have very advanced business intelligence dashboards sitting on top of it. But actually, the journey we described in terms of developing the value intelligence model will again bring in the costing data into our repository, so we can triangulate that element together. But it's all there. We use it on a routinely basis, and we're very good at it as well. What we're not good at it, we're getting better, is triangulating it. And we have triangulated different pieces of work, and more than happy to share it at a different points. Diabetes, for example, is an excellent example of it. Adele.
Yes.
Brilliant. Thank you. Awesome. So I've got another 2 minutes. So these just got me there. So let me have a think. So Joe Ferris has asked a little bit about kind of how Wales are working with the wider UK system around the data collection and kind of looking at, let me find the exact, so yeah, how the rest of the the UK is able to access the data. And I think you've covered that a little bit around kind of access to data, and I'm sure the access to that from our colleagues across the water in the NHS of England is very similar. But have there been discussions about how we can align or support and collaborate on what they're doing over there? Sorry, I probably jumbled that question up in a different way than it was asked, but I think overall, with what we're doing in Wales, is that applicable, and have conversations happen with our colleagues across the water?
Yeah, Sally, I will cover the HQIP part of it. Hopefully that helps. Now, HQIP is an organization that collects clinical audit data, and Adele, happy for you to kind of compliment me on this one. I might not have wider knowledge about this. So HQIP is the clinical registry data, which is UK wide. And as Sally alluded to, we don't have that in our GIF because health boards directly. So it's a UK wide data set rather than a Wales data set. And again, we are based on the new, I guess, the new. So we are working with HQIP at the moment to understand how we can start accessing that data set as a part of our value intelligence framework going forward. And of course, when it comes to data dictionary, Sally, do you want to talk a little bit about it?
Yeah, I mean, we do have our own NHS Wales data dictionary. It is very similar to the England one, but we do have our own special, our nuances within Wales. Some data is comparable, others isn't. We use the same coding for secondary care and primary care data as they use in England, so that data could be comparable. There is caveats that we know that apply to Wales, that apply to different organisations within Wales, and there will be similar things for England. So yeah, we can compare some data between us and England, but there's always things that we have to bear in mind at the same time.
Yeah, I think just to add on that, I think Joe's come back actually and said I think she was asking something slightly different, is how are we collaborating across the UK when we've got the data set. It's a really interesting one because believe it or not, Wales is much further ahead with some of this, and actually, internationally we've spoken to many organisations and they haven't cracked this either. So we do have a number of mechanisms through things like partnerships that we've got with King's and others where we are starting to share some of these opportunities, but again, we are still quite immature in that space yet.
There's also, just to add on that as well, there's, as we've mentioned, value-based healthcare is growing globally and across Europe, and there is a lot of work being done by the European Alliance and the Global Economic Forum, looking at worldwide observatories where we can all put the information together, and that helps the bigger picture as well. But that's a bigger piece of work that's ongoing, and I think we're all learning from this. And as you said, your insights and input and suggestions are just really welcome in this area as well.
Yeah, no, that's really useful, Dee, because actually we haven't mentioned the fact that Wales has been acknowledged as a global partner in the coalition with the World Economic Forum, and as a result of that, you're absolutely right, we will be working with them on all of these aspects of work.
Okay, so I'm going to call an end to the questions. They're not going to disappear, so we will be collecting them out of the chat. And what I'd like to do is to share them with our presenters, and I'm sure you'll have some for Brian following his presentation as well, and we'll gather in the answers and we'll forward them on with the presentations and with the recording of today. if that's okay with everybody. So I'm going to move on now. And Brian, thank you for your patience and joining us today. Really looking forward to your presentation on the work that you've been doing with the NHS supply chain and value-based healthcare. So over to you.
Okay. I think it's still morning everyone from a cloudy Liverpool. Hope everyone's okay. Can you see my presentation there, Jonathan?
Yeah.
Yes, we can see it.
Is that okay? Yeah. Great. Brian Mangan and the Value-Based Procurement Project Lead for NHS Supply Chain. I'm an independent consultant. I've been working with supply chain since 2019, and I do some work with industry as well when it comes to trying to really understand what VBP is all about. I have had the pleasure of working with my colleagues in Wales for a number of years. I know Adele fairly well, and I say, you know, the value-based procurement community is quite a small one. So I've been working on this now since about 2014 is when I started looking at it, when I've been jobbing the NHS. And today's presentation probably take about 20 minutes or so, and I'm happy to take questions at the end. It's really to give you a bit of a view about, you know, for me, what VBP is. It's the why and the what. And listening to the presentation that I've done over the last sort of 20 minutes or so, I think it was important to draw a distinction about the approach that we're taking in the English NHS to yourselves in looking at VBP compared with value-based healthcare. And again, I caught what Adele was talking about at the end. And then it's about the approach that I've taken in the actual pilot project that I started off, and some of the lessons that we've learned and where we're going to take it. So in terms of the why and the what, I spent about 15 years in procurement in the NHS, and this is what I've come to know and love as my procurement cycle of doom, where every year you get your annual savings target, you go out, you produce your work plans, you look at your frameworks, and then you go out and you're challenging the suppliers. And predominantly that is largely around the price of the product. So that is say, you know, you've got a quality, you set your specification, but then the assessment is normally around the price of the product. You record your savings, and then you do this year in, year out. And for me, what I kind of realised when I got a strategic role in the NHS when I started looking at VBP is, you know, procurement are becoming victims of their own success. I know that you've got a really effective procurement departments in Wales who go out and challenge suppliers on a regular basis. And I think the question is, you know, once you've looked at price, what do you do next, especially when the fact that you've got ever increasing financial demands on healthcare. So, you know, if you're looking at trying to reduce the price of the product, at some point you are going to flatline. So you need to do things differently. And then the other thing is that, is it really just by looking at the product price, is it actually contributing to the bigger challenges that we're facing in COVID? You know, we need to find ways to support organisations to release capacity, make them more effective. And for me, it's trying to position procurement in a way that is different, that's more strategic, that's making this wider contribution to the healthcare. And then the final part is that, again, we're looking at in England about the introduction of integrated care systems. So traditionally, what you might find is that you may find that, you know, there could be an increase in the price of a product for an acute, but it could have a whole system approach. It could have a whole system reduction across the whole system. So we need to start doing things differently. And then my sort of interpretation of VBP is this holistic approach, one where the procurement departments are allocated pathway savings and efficiency targets. We work with stakeholders, we work with clinicians to identify what the challenges are within the pathway, what needs to change and by how much. And then we work with industry to actually see if there's the capacity and the capability to do it. And then when we get to the tendering side of things, then we're going out and rather just having quite a narrow, if you like, price-focused evaluation, is we're trying to take into account the whole life costs. VBP for me, it's not rocket science, it's whole life costing for healthcare. And that's the kind of the approach that I'm looking to take. And then the final piece of the jigsaw, if you like, is one whereby traditionally, my experiences with NHS procurers, they tend to let and forget. They let the contract and then they just leave it. And then the only time you'll have a discussion with suppliers, will have a discussion with the procurer is when it comes around, challenging them with the price. And for me, this is about partnership working. It's about working with industry in a different way and seeing industry as very much as central to the solution, if you like, to the solution. I'm moving forward to try and drive value throughout the life of the contract. So again, that's just my interpretation of VBP. So in terms of value-based healthcare, I think that traditionally what I've found is that industry tends to focus on that, and they come into the English NHS and they're trying to sell products, and they're looking at value-based healthcare, which for me is, it's the utopia of where you need to get to. And I really do applaud the work that's being done in Wales in trying to adopt that, because you've got the systems and you've got the culture in place. I know a lot of the senior management, the leaders in Wales have been over to Harvard and done the value-based healthcare course. So really, your culture is slightly different to the one that's in the English NHS. We're predominantly we're obsessed by price, and for me, that if I was trying to lead a project that was said, okay, we want to go from this sort of quite transactional, quite narrow focus of looking at price, I said we want to go to value-based healthcare. We haven't got the systems in place. Again, at caught the end of the previous presentation, talking on systems. We haven't got that in place. We haven't got the culture. It's hard enough trying to get people to understand that you might pay a little bit more for a product, but you're going to use less of it. So for me, value-based procurement is a stepping stone. It's a stepping stone towards trying to get to VBHC, and it's one that focuses very much on, again, working with clinicians, looking at the whole pathway and seeing what the opportunities are within that. So that's kind of just the approach, the overall approach in that we're taking, and hopefully it puts in some kind of context about what VBP is. So when it comes to the actual project itself that I was brought in to do, it started back in 2019, which I know probably for all of us seemed like a lifetime ago, and it was a proof of concept project. So the executives in Supply Chain Coordination Limited, who's the management function for NHS supply chain. So we often get suppliers coming in trying to sell value, and we wanted to run a pilot study. And they started off and they said, we wanted to do between 3 or 4 pilots. And after I was employed and I was there for a couple of weeks, they said, we wanted to do between 15 and 20. So someone who likes a challenge, they decided to stick it out. But what they did was they had some parameters that they put in place, was to say, the pilots have got to be small scale. They've got to deliver a benefit within 3 to 6 months. And there has to be a one-to-one relationship between the product or solution and the benefit that was delivered. So we went out, I was directed to talk to the top 20 strategic suppliers and a number of SMEs. We filtered it out, kind of basic process. We filtered it out and we got 13 projects out of 27. Unfortunately, the COVID impacted on a few of them, so we weren't able to report the outcomes from them. But what we found was we had these 10 pilots. A couple of them didn't actually deliver what they thought they were going to, but it didn't matter because we purposely kept the pilots anonymised, so there was a learning for it, for both the supplier who was involved and the organisations as well. But we did have eight examples which we're in the process now of trying to write up and make them case studies. But again, there's been some challenges re-engaging with organisations, as I'm sure you can appreciate, with the challenges over COVID. But what we did find was that value, if you like, was created around 5 main areas, from the quite basic, where you pay a bit more but you use less of it, a reduction in consumption, right the way through to the other end, where we had a couple of projects whereby the actual the product and the solution, there was this clear one-to-one relationship between a reduction in infection. So it was very, very defined. And we had the value was created across a few other areas. For me, one of the really interesting ways to demonstrate this was around, we had 3 projects to help move people from an inpatient to a day case. So quite tangible, quite measurable. You can see that by using the solution, there was a reduction. You know, previously the operations were quite invasive. People were in hospital for 3 days, an hour and a half in theatres, and then it moved to a day case in 20-25 minutes. So you can kind of touch and feel the benefits that are actually being delivered. Another one was a technology that allowed people to have antibiotics at home, which released 10 days for every patient. And again, it wasn't just passing the cost back into community. There was a real benefit that could be delivered from that. And another area was around the use of transnasal endoscopy, where it was quicker, better for the patients, and could be done by less qualified staff, so actually cheaper to perform. And so what I'm doing at the moment is I'm just in the process now of trying to get the case studies written up, and they will be available on the NHS Supply Chain website. I'll give you the link at the end of this. Probably we're going to have a few of them all being well later on this summer, and probably some in early autumn as well. That's just again just to sort of put it in some kind of context. Now, we learned quite a bit through the project. I think the first area was that value. You know, value means different things to different people. It's quite a strange word. It's a bit like quality, for those of you old enough, when there was the total quality management movement that came out in the late 80s, early 90s. You know, it was all around quality, but the word quality means different things to different people, and that's definitely the case here in when we're looking at value, and that really links into the fact that there were a number of financial challenges in recognising value. So we had one in looking at value. For me, it's got to make this material difference. There's no point in buying a solution if you can't do something with it. So I had one supplier came in to us as part of the pilot project and said, well, we can save you 3 minutes in theatres, and that will save you £2 million. And I did spend quite a lot of time, you know, being quite disparaging about that claim. But when I've reflected on it, I think for me, you know, it's incumbent on the health system to really articulate what value means to them. So in that particular case, if I'd have said, well, listen, for us, a material opportunity is if you save half an hour in theatres because we can do something about it, then they could have actually done, you know, that would have made the difference. So people can go away, suppliers can go away and say, well, okay, yeah, I can see that. I've got a solution or I've got a product that can make a difference. I think it really is very much incumbent on the NHS and health systems around the world to just be dead clear on what value means to them. The other challenge that I found was that, you know, it's about this one-to-one relationship. So you quite often get SSIs is obviously a massive challenge for the health systems, but when you get organisations coming in and say, well, I've got a product and it'll reduce your SSI, it's really a question I would say, well, actually, can you ring fence it? Can you ring fence the fact that your product, your solution, there's a direct one-to-one relationship between the introduction of that and a reduction in a surgical site infection, when potentially there could be other factors that are involved in. And if you can do that, if you can isolate it, then great. But these are things that need to be considered. And then the final bit is how do you measure it? I'm quite a simple bloke, and for me, you know, the easier you make it, the better it is. And I think one of the challenges that I've seen with value-based healthcare over the years is that there are multiple measures that have been applied to it. And for me, it's about looking at using the old 80-20 rule. You know, have you got 20% of the measures that actually deliver 80% of the value, and then very much focus on that? And that for me is a way, you know, when we're trying to introduce change, and the more complex we make it, the more resistance we'll get. So it's trying to make this relatively straightforward for both buyers and suppliers to understand. And then the other area that came out of the research that I did was talking to finance directors. They said, well, okay, I kind of get what you're saying. I understand what you're trying to do. But one of the things I'm concerned about is it's a bit of a risk for me, this, if we're doing something different. So how can what assurance am I going to get from a supplier that the benefits are going to be delivered? So as part of the toolkit that I created for NHS supply chain, I've done this thing called a value-based procurement assurance framework. And what I'm saying is that it's about really, being clear that yes, we will, as an organisation, as an NHS, we will be prepared to pay more for a solution or a product that's going to deliver something, but we need confidence that it's going to be. And I suppose the colloquial way of putting it is, are suppliers prepared to put the money where their mouth is? And if they are, great. And then potentially within that framework, and it's just an idea, it's just a series of suggestions. It's then saying, okay, it's about working together in partnership. So it's about saying, okay, we as an NHS, we have responsibilities, and provided we are our end of the bargain up, then it's about the supplier, engaging, actually doing their bit. And if it doesn't work, then it's about sort of reverting back to a cost neutral position. But alternatively, there are suggestions in there to say, okay, if it exceeds our expectations, then what kind of gain share could be achieved from there? And so we're at a very early stage with this now. I'm just kind of putting ideas out there to try and get people thinking a bit differently. In terms of the, the journey that we're on, we've finished the pilot phase it lasted for the best part of a couple of years by the time the report was finished. I'm now very much into this phase 2, which I'm referring to being an action learning phase. So what I've done is I've produced a report which is publicly available. It's on on the NHS supply chain website, and I've spent the last sort of 6 to 8 weeks working with the category tower service providers. I've done a lot of training with them, and what we're trying to do now is develop a series of projects that have got more sort of depth to them, and really applying the toolkit and to some degree putting it together, probably breaking it and putting it back together again over the course of the next 12 months to see, okay, how can it work in practice, with a view then to really, in the course, all being well, from next year, from in 2022, start making this business as usual. And that's the ambition of where we want to get to. So I think in summary, I say it hasn't been a fairly short presentation. I'm just mindful of the time. I think in making VBP happen, you've got to have clinicians on side. It is about clinical leadership. Ultimately, when we're talking about pathways and things like that, it will require a change in practice at the end of it. We have to get clinicians on side. And when I've spoken to clinical people over the years, when it comes to the value-based procurement, to me, it's like pushing on an open door. People say, okay, I can see what you're trying to do. I know you're not just trying to get us the cheapest product. You're trying to make the patient outcomes better. You're trying to make the process better. You're trying to make our lives better in lots of ways. And it's about making sure that they're on side from the very beginning. It is about this partnership working when it comes to buyers and suppliers. I have to say, I've probably been one of the world's worst. I'm the head of procurement in terms of my adversarial relationships with suppliers. I have mellowed, but VBP is very much part of that. It's about working in partnership. And there's things that we need to do as an NHS, and there's things that suppliers need to do as well. And again, in the other side of the work that I do, I'm quite clear that industry needs to change. It needs to be more transparent. It needs to be able to build this trust, because that's what it's all about. It's about having this true partnership working approach. We need to get finance on side. And again, I know I've spoken to colleagues in Wales. You set up slightly different to us, and there's a lot of a lot of work that's been done on it. In the English NHS, there's still more that we need to do, and we're trying to engage across the board. Literally, it's a top-down and bottom-up approach to get people to recognise efficiency benefits. And then the final bit is about procurement. It's about engaging with procurement teams to move what we're doing from, in some respects, it's a bit transactional, isn't it? The work that we're doing, despite focus on price, and making it more strategic, so that as a profession, that we can make a significant contribution to health systems, in England, Wales, and literally across the world. So that's all the presentation from me. We've now got a web page, so I suppose in some respects we must have made it. We must be getting a bit of traction. We've got our own web page on the NHS Supply Chain website. You can download the report there if you haven't seen it, and that's where we will be publishing the case studies as well over the course of, say, the next 3 to 6 months. And that's it from me. I know we've got questions. I purposely tried not to look at the box that was popping up, because I get distracted very easily.
Hi, Brian. So thank you so much for that really insightful presentation, and I think also a demonstration about how we are sharing learning, across the UK, and in the different areas that have been progressed. John has been keeping an eye on the Poppy box for us, and collating some of those questions. So we do have a little bit of time here to pick up some of those.
Yeah, thanks, Dee. And Brian, I did share the link to the PDF for the report in the chat, so everyone's got access to it. Okay. So I hope that might be helpful for everyone. So I'll start with a question from Liam Perrott. So Liam kind of talked about, so you've talked quite a lot about the eye of the beholder, and in the process of almost whittling down those submissions that came into the pilot, what was the value in your eye, and how did you work through those submissions to whittle them down? Now, you've given us some insight into they had to be able to demonstrate an improvement within 3 to 6 months and demonstrate a direct improvement. But what were the other factors that kind of came in there for you? And I suppose Liam's given the example of supplier for qualification for that process.
Well, I see with that, it was just they were all, there wasn't any contracting that was done. It was just they were all part of the framework, and it was literally, they were only small scale pilots, so they were quite selective. It was just, I was advised to contact the top 20 strategic suppliers, so there wasn't any contracting involved in it. And literally what I did was I set a group up, like a cross-functional group with finance, clinical and procurement on it, and we were looking just to see, okay, what, some of the inpatient to day case stuff, it's a bit of a no-brainer. Either it does it or it doesn't. And the other areas where it was a bit more tenuous, the link, or it was going to take longer than the 3 to 6 months, there was a lot of pressure put on to try and get some examples that we can start working through. So that's what we did. It was literally a question of it being very apparent from the submissions that were put forward that it could actually be delivered in a timescale and there were tangible and measurable benefits. So how easy was it to measure? We didn't have time to do a 12-month study on it. It was, what can you get up and running?
Yeah, and a big part of this is working with the willing and the ones that are there to work with it, and yeah, I think that's important. Yeah. Ravi has asked about how the supply chain assurance framework, which you've talked about, that you've kind of put together as almost suggestions to how we can move forward with this in value-based procurement. How does that then filter down and work in practice, or do you envisage that working in practice when it comes down to an NHS trust, a CCG, or an ICS level, from a contractual perspective? So I suppose, yeah, where do you envisage that the challenges or the opportunities when it moves down to that more local and trust level?
So what we're doing, I think where NHS Supply Chain and look at us, they've invested made an investment in value-based procurement. So what we're trying to do is we're trying to develop a process. We've got the Healthcare Suppliers Association engaged as well, which I know that NHS Wales are part of, and it's very much then trying to develop at a national level an approach to the national contracting, with the view then, I think that organisations at a local level will be playing a part of that. I mean, when it comes to VBP, the role for procurement is very much around managing suppliers going forward to ensure that things are being delivered, because you can only, the value that will be created is, once you can reduce the price of a product, it's blanket right the way across the board. Whereas when it comes to the pathway savings and efficiency benefits, it does require support from procurement to ensure that it's actually being delivered at a local level. So we say, for me, we are at the start of this. The intention is that we're going to use the action learning to get the process quite robust and working. And at a national level, then I think it's a view of them looking to engage with HCSA and also NHS-ENI. They've got the procurement target operating model to see what that might look like at a local level. But I think for suppliers, I think the key is that we're trying to get a recognition of the efficiency benefits, whereas that's traditionally been quite a blocker. So if an organisation was to say, I've got a value solution in the past, but it might cost you a little bit more. In the past, it would be, so look, I'm not interested because my target only allows me to reduce savings. What we're trying to do is move the agenda along to say, actually, this is going to help you release capacity, and then get procurement measured and recognised for that.
Absolutely. And there's been a number of comments, and I think this has been a thread that has run through the chat in me trying to keep up with it. Collaboration is key, you know, and early collaboration. And I think someone's talked, I think it was Rob Harris talked about, you know, that collaborative approach and having the likes of patients and clinicians involved very early on. And I suppose as an ex-clinician, to fathom the thought of working closely with our procurement teams to kind of really work out how we develop and move things forward would have been just unheard of. But I think it has to be that the way we move forward, and I think that is coming through now very clearly. And there's also an ambition from everyone on the call to work very much closely on doing that. So that is very much shining through everything that's kind of been said in the chat here. So I suppose my last question, Brian, what's the next steps? What's the most important thing for you? What's a priority for you now moving forward with your project? You know, and culture you said is really important. But what's your kind of next thing to tackle now in the next 12 months for you in this project? Well,
if I can give you, there's two things. The first one is the recognition of value, a standard recognition of value efficiency savings. I think for us, I mean, I'm just being straight about that. That's a big area. And once we can do that, everyone's at the moment. When it comes to length of stay, as part of the pilot project, we had people who said, you know, we'll allocate a nominal fee of £350 a day. Some had 220, some had 450. You went to another hospital, they said, don't talk to me about length of stay, talk to me about release capacity. So for me, that's the first thing. It's about trying to get this common language of efficiency, and that's one of the things that I'm working on. And then the final one, it's about this action learning thing. It's about having some project. The pilots are only small scale. If you're talking three to 6 months, we're trying to do something that really demonstrates that value-based procurement can have a significant impact for a health system, and that's what we're trying to do.
Brilliant, and we'll be closely watching and probably being in close contact over the next 12 months.
Yeah, well, it is. So it's a small community. You know, I've spoken to Adele a number of times, and Andy Smallwood. You know, we're all trying to. You know, I do some work in MedTech Europe and in other countries as well. Everybody's looking at it. I think someone said before, you know, loads of people looking at it. And what I'm trying to do is what I was surprised at when I first got involved in working with people across Europe is procurement's the same anywhere you go. We all got the same challenges. It's really quite strange. You can pick up the phone to me, like I've got a mate in Canada. It's like talking to someone in the next room. Everybody's got the same challenges. So I think, you know, there is a lot of opportunity and a lot of learning that we can share and bring together.
Absolutely. Well, thank you very much for joining us. I'm going to pass to Dee for the last 5 minutes, and yeah, thank you again, Brian.
Is that okay? Okay.
Fantastic.
Okay.
So thank you very much, Brian. Thank you very much to all of our speakers today. Thank you very much for joining us. I hope that it has been useful. The chat has been non-stop. It's been binging away and lots of really good thoughts, insights, questions. As I've said, we are going to be downloading this chat, sharing it with our speakers. So any unanswered questions, we'll seek to get those answers. Continue on the collaboration front, but also, as we said, it's that co-creation. So our work will continue with you. So if you haven't already met with us to talk about your organisation's approach to value-based healthcare, then please do get in touch with myself and Jonathan. as you've already seen in the chat as well, where people have identified that they've got some solutions or some chats, and the NHS, our health and social care services, are open to listening and to identifying where we can all work together and where we can come together on these national models and make sure that industry are at the forefront and bringing forward their challenges and questions. You know, it's really important, and I'm really pleased that this platform enables us to do that. And I really can't stress enough, actually, how welcome our national value-based healthcare colleagues have said that they really value this opportunity to come and speak to you, to come and share what they're doing with you, but also for you to challenge them, to identify where you can participate or what's stopping you from participating. So we're really keen to keep this forum going. We are here to work with you in the meantime and to share your opportunities and work with you on your value propositions to identify where they can meet the challenges and those wicked problems that Navjot and others referred to earlier. But as we've all said all the way through this, it is a continual learning platform. It is a continual sharing, and only by building that trust and that respect and that openness and feeling that you can ask the questions and that people are listening and that they're being taken into consideration, will we all be able to move forward on this. So we'll gather the questions, we will seek to get the responses. And Navjot's actually shared with me a slide that will help to inform the intelligence for value model that's being developed around data and some of those questions. So I'm going to include that in my thank you email. Now, normally out of courtesy, I would send my thank you email this afternoon, but as I want to gather in the presentations, the questions and some other bits in there for you, it will probably be the beginning of next week. But we'll have the recording, we'll have the presentation, we'll have that slide for you and your organisation to think about value data and capabilities that we've spoken about. If there are any further questions, then again, contact myself and Jonathan, and in our ongoing discussions and work with the national team and with the health boards and with procurement, you know, that's how we'll seek to address them and to move them forward. So thank you very much, and I'm sure you'll all join with me in thanking and applauding our speakers for speaking so openly and sharing all of the work that they've been doing. Thank you all for joining us. Thanks to Priya and our comms team for popping this all together for us, keeping us on track and making sure that everything could be shared. Let's keep the conversation going. Let's keep speaking, and we'll send you all of the details soon for the next SIG, and I'll probably be reaching out to some of you. I'd like to get to know a bit more about some of you as members and to share that across the networks. And we're also working with our Simply Do provider to how we can create that ongoing network that enables us to catch up and share ideas and share work in between meetings as well. So we'll share some further details on that. But thank you very much. Don't forget the value-based healthcare courses are still open. I can say this, I'm on my last one this afternoon from the EdExec course at Swansea at the Value-Based Healthcare Academy. It's fantastic. It's great working with leaders in health, social care and industry, identifying and learning together on these issues, and it will really grow that alumni and our understanding of value-based healthcare. So that's all from me. Thank you all so much. We're right on time, which is fantastic. I always like to give maybe about 30 seconds back, and we'll speak to you all soon. Diolch yn fawr. Thank you very much.
Thanks, everyone.
Thanks. Bye.